So now we're on the muscles of mastication, innervated by the trigeminal nerve. We have 4 muscles of mastication. You have the masseter, the temporalis, and then the medial and lateral pterygoid. The masseter is the most powerful one. It's that big one right on the side. The function of the masseter is to close the jaw during mastication. Then we have the temporalis. The temporalis retrudes and elevates the jaw by pulling it backwards and upwards. It's also responsible for maintaining the mandible when it's at rest. So when your mouth is at rest, it helps to keep, remember, your teeth are not in occlusion when you're at rest. And so it is what stabilizes the jaw. And then you've got your medial pterygoid, which also closes the jaw by elevating it. And then you've got the lateral pterygoid. The lateral pterygoid is responsible for lateral movement or side to side when you tell your patient to shift your jaw side to side. The buccinator is listed in this, but the buccinator is not a muscle of mastication. It assists the muscles of mastication. And what it does is it pulls the cheeks inward. And so as it pulls the cheeks inward, it helps to keep food on the occlusal surfaces of the teeth. And that's pretty much what it functions to do. Let's see. Then other muscles we have, the buccinator is actually a muscle of facial expression. Other muscles of facial expression that we studied were the epicranius, which raises the eyebrows, or lets you do this. Then we've got your orbicularis oculi that closes the eye. Remember, when it comes to the muscles, some basic terminology. If it says orbicularis, it orbits. So it goes around something. So an oculi is the eye, oris is the mouth. So if it's orbicularis oculi, it circles the eye. So it's going to create some movement to the eye. If it says orbicularis oris, it circles the mouth, and so it's going to create some movement to the mouth. In this case, the orbicularis oculi closes the eye. And then the orbicularis oris closes and protrudes the lips, like in kissing. And then you've got the risorius, which moves the angles of the mouth. And then we've got like the levator ones. We've got levator anguli, which if you hear angle, they mean the angles or the corners of the mouth. If you read labii, they mean the lips. So levator would lift, depressor would lower it down. So like levator labii would lift the upper lip. Depressor anguli would depress the lip or pull it down. Or I mean, not the lip. Depressor anguli would move the corners of the mouth. So if it says levator, it lifts, anguli, the corners, labii, the lips. Superioris would be like the above or the upper. Inferioris would be like the lower lip. So if you just see those words and you're not sure what exactly they're talking about, just kind of break it down by the separate words so that you can kind of figure out where it's coming from. So if it's going to have like raise the lip versus the corners of the mouth. So the corners of the mouth are going to be more like the smile, the frown, those kinds of things. Your platysma depresses the jaw and widens the mouth. And then your mentalis is down here. It protrudes the lower lip and raises the chin. Does anybody have any questions on the muscles of facial expression? So sometimes they'll mix them up on the test, like they'll have, it'll ask you about a muscle of facial expression, but they'll throw a muscle of mastication in there. So you should recognize right away that that's not a facial expression and be able to eliminate the ones that don't fit. I've always been, when you're doing a multiple choice test, a big one to eliminate things that don't belong. And then you can get yourself down to like 2, 3, or maybe even only 2 answers. Suprahyoid muscles. The suprahyoid muscles are going to elevate the hyoid bone for swallowing. So any of your suprahyoids are going to, you've got your digastric, your geniohyoid, your mylohyoid, and your stylohyoid. And they're going to elevate the hyoid bone for swallowing or assist you in swallowing. Let's see. The tongue muscles, the three tongue muscles, we had the genioglossus, which protrudes and depresses the tongue. So a student in a previous cohort said, think of the genioglossus as we stick our tongue out at geniuses. So you protrude your tongue, you stick out your tongue. The hyoglossus depresses and retracts the tongue, and the styloglossus elevates and retracts the tongue. So kind of like in the swallowing process. Anybody have questions about the tongue muscle? Those are all extrinsic muscles of the tongue. They, the extrinsic muscles of the tongue are controlled by the hypoglossal nerve. It's a motor nerve, so it causes motor movement. The taste sensation comes from different nerves. We'll talk about those later. The muscles of the neck, the two that we studied are the trapezius, which is what helps you shrug your shoulders or move your shoulders up and down. And then the sternocleidomastoid helps you turn your head and move your head from side to side. It's the big, thick muscle right on the side that you palpate when you're doing your extra-oral exam. Let's see. Then on to the nervous system. So keep in mind when you're studying too that we're covering all the head and neck stuff, but there's also going to be some stuff from your gen eds, some basic nervous system stuff like what's sympathetic and parasympathetic and neurons and neurotransmitters and all that kind of stuff. So make sure you go back and to your gen ed stuff and study some of that. It's going to work the same with like arteries and veins. You know, we studied the ones of the head and neck, but it's going to touch on your gen ed stuff too, like the arteries and veins in the heart, and the ones that come off the heart and things like that. So make sure you go back through your gen ed stuff and review that as well. For the nerves, we have the ones we really pay big attention to are the trigeminal. The trigeminal has both motor and sensory. It has the motor that moves the muscles of mastication, and it has sensory or afferent. So the efferent is for motor, afferent is sensory. Think of the sensory as it causes a sensation. So it's going to be causing a feeling, whether it's hot, cold, sweet. It's going to detect some sort of sensation. The afferent or motor are going to cause something to do something, an action. They're going to put an action into place. So the sensory ones, the trigeminal brings sensations to the facial skin, the teeth, and the oral cavity, and the tongue. There's three branches, the ophthalmic, the maxillary, and the mandibular. The ophthalmic passes through the superior orbital fissure, the maxillary through the foramen rotundum. The maxillary nerve branches into the PSA, MSA, and ASA, the greater palatine, and nasopalatine. Now, doesn't this seem so much easier than when you were taking this during term 3 in anatomy, now that you've been giving injections and all that kind of stuff? Come on, tell me it seems easier now.
It is easier.
All right. So you know PSA innervates your molars, your three maxillary molars, with the exception of the mesial buccal root of the first molar. The MSA is the premolars and the mesial buccal root of the first molar. The ASA are the incisors and canines. The greater palatine does the palatal gingiva from the molars and premolars, and the nasopalatine does the palatal gingiva from canine to canine. Then you've got the mandibular branch, which passes through the foramen ovale, and it has the inferior alveolar, the buccal, the lingual, and the mental. Then you've got your facial or cranial nerve 7, which is also both motor and sensory. So it provides motor innervation to the muscles of facial expression, and it provides sensory innervation to the skin around the ear, and then the taste sensation to the anterior 2/3 or the body of the tongue. So those are the important ones to remember for the facial. It provides motor or efferent innervation to the muscles of facial expression, so when you smile. And then it provides taste sensation to the anterior 2/3 or in other words, the body of the tongue. It has two branches, the greater petrosal and the chord of tympani. The greater petrosal also passes through the stylomastoid foramen. And then the chord of tympani provides efferent innervation for the submandibular and sublingual salivary glands. The facial nerve is the one that is involved with the condition called Bell's palsy. Then we have the glossopharyngeal, which is the 9th cranial nerve, is also mixed, both efferent and afferent. It's efferent for the parotid gland. And then you've also got the afferent. It gives the taste and general sensation to the base of the tongue. So the cranial nerve 7, the facial, provides taste for the anterior or the body of the tongue. And then the 9th or glossopharyngeal provides taste or general sensation to the base of the tongue. And then you've got your hypoglossal, which is the 12th cranial nerve, and it provides motor innervation or efferent innervation to the intrinsic and extrinsic muscles of the tongue. So it's what makes the tongue move. And then we've also got the 10th cranial nerve, which is the vagus, which is also both, and it provides efferent innervation to the soft palate muscles, the pharynx and the larynx. Does anybody have any questions about that? Okay, so let's talk a little bit about salivary glands. So you've got 3 major salivary glands. You've got your parotid gland, your submandibular salivary gland, and your sublingual salivary gland. So your parotid gland is the biggest one in size, but it's not the biggest producer of saliva. It produces serous secretions, and it is known for the opening the Stenson's duct. It opens through the parotid papilla into the oral cavity, which is located on the buccal mucosa next to or adjacent to the maxillary second molar. It's a little flap of tissue. It gets its innervation from the glossopharyngeal nerve. So the interesting thing about the parotid gland that Ford seems to like is that the 7th cranial nerve passes through the parotid gland, but it doesn't innervate it. It's innervated by the 9th, or the glossopharyngeal. The parotid gland gets its blood supply from the external carotid artery, and it drains its lymph to the deep parotid node. Then you've got your submandibular salivary gland. Your submandibular is the next biggest in size, so it's not the biggest, but it has the most saliva or salivary secretions. 60% is from the submandibular salivary gland, and it's mostly mucus secretion. It is associated with the Wharton's duct, and the Wharton's duct is found in the sublingual caruncle, which is underneath the tongue. It's those 2 little round balls that are on the lingual frenum. They get their blood supply, the submandibular salivary glands get their blood supply from the facial and lingual arteries, and they drain their lymph to the submandibular lymph node. Then we have the sublingual salivary gland. The sublingual is the smallest. It's associated with the Bartholin's duct, and it has a combination of serous and mucus. So it's pretty easy to remember that the parotid is first, the biggest, and it's serous. The submandibular is second biggest, and it's mostly mucus. And then the sublingual is a combination of both. Let's see. It gets its blood supply from the sublingual and submental arteries, and its lymph drains to the submandibular lymph node. Does anybody have any questions about the submandibular glands?
I have a question. At the very end of this chapter, there's a question that says the parotid gland produces the least volume of saliva because it is the smallest salivary gland. And in the answers for it, it says that the statement is correct, but the reason is not correct. So I thought that the sublingual produces the least amount.
What was the first part of the statement?
And it says the parotid gland produces the least volume of saliva.
And that says that's correct?
That's what the book, or that's what the answer was, said it was correct, but I don't think that's correct.
I don't think that's correct either.
Okay.
Is this a pre-test you were looking at, or?
No, it's at the end of our, chapter 4. It's like the test at the end of our book.
Our anatomy book?
No, for the Darby's comprehensive review.
Oh, no, yeah. No, I would not think that that's correct.
Okay, because I was like, I think the sublingual is the least amount, or the least amount of volume of saliva.
It is.
Okay. All right. Thank you.
Yeah, every once in a while there is an incorrect answer in those books. And I do remember somebody, in the past, bringing up that Darby's had a couple of them in some of their different chapters. And I'm sure that the book that you have is probably just kind of a reprint with maybe a little bit of updating. So as far as let's see, then there's a review on the muscles of mastication. I don't know why I chose to do them twice. I guess maybe the most important thing I wanted to highlight on the muscles of mastication was that the lateral pterygoid is the one that's responsible for lateral movements, and that the buccinator they're going to try and throw in there as a muscle of mastication, and it's not a muscle of mastication. What else do we have? So the other cranial nerves that we need to talk about. So remember you did that picture with the face, and it had you do the number 7. Do you guys remember doing that picture?
Yes, that picture is so helpful.
If you get a chance, just Google that. It's only a 3 or 4 minute YouTube video, but if you get a chance, look at that video and just kind of play with it for a few minutes, just as sort of a refresher. And then there was a mnemonic that I gave you back in class that helped you know whether they were sensory or motor or both. Do you guys remember that at all? It was some say money matters, but my brother says big brains matter more. Does that ring a bell? So that
Yep.
It goes in the order then of sensory, motor, and then both. So that would help you if you could memorize that one statement again, to answer some questions about the trigeminal or the facial or the glossopharyngeal, as far as what they innervate. Most of them the other ones you can kind of figure out just based on that, if you drew that face again and where you put the numbers. So the ones that have to do with the eyes, they'll have, I don't think they're going to go that in detail, which moves the eyeball and which one moves the, they're going to just have something about the eyes. So if you can remember which 3 are choices for the eyes, by going through that picture again, that would be helpful. But we can't really eliminate anything because anything's a possibility when they're asking the questions. Let's see, what else do we need to know about the nerves? Because it seems like it's so important. Know the Bell's palsy one. It's the facial nerve. The hypoglossal. So the hypoglossal nerve is the one that gives motor innervation to the movement of the tongue. So oftentimes, if there's a problem with that nerve, like if it gets injured or damaged, you can have some problems with the deviation of the tongue or the movement of the tongue, which would affect speech. The trigeminal nerve is responsible for most of the periodontium in the teeth. The glossopharyngeal and the hypoglossal have to do with the tongue. Some other, there's a whole list here I've got of different muscles and stuff. I'm going to throw out a couple other ones for you to just kind of have an idea of. Those would be like the muscles that go with the intrinsic muscles of the tongue. We didn't spend any time on the intrinsic muscles of the tongue. Just be aware of them. You've got some of the muscles that came around, like the arch of the throat, like the levator veli palatini, which is responsible for elevating the soft palate when you swallow. Let's see, which other ones do we have that we didn't really talk too much about? The stylopharyngesis elevates the pharynx to help with swallowing. The tensor veli palatini also stretches the soft palate. So just a few other ones to throw out at you to kind of pay attention to. Does anybody have any questions? Oh, lymphatic drainage. So as far as the lymph nodes and the drainage of the lymph nodes, so the all of your teeth, with the exception of the maxillary third molars and the mandibular incisors, all of the rest of your teeth drain into the submandibular lymph node. The mandibular incisors drain into the submental underneath the chin. The submental drain back into the submandibular. So all of it ends up in the submandibular, but the primary drainage for the lower incisors is the submental, underneath the chin. Superficial nodes are going to be usually nodes that you would palpate. So when you're doing your extra oral exam, superficial nodes are going to be closer to the surface, right? And the deep nodes are usually ones you're not going to be able to palpate because they're away from or they're too deep in. It's just kind of keeping the nodes very basic. I think most of what they would want to know is going to be pretty basic. Any questions? Okay, so we'll go ahead then and as far as arteries go, arteries and nerves run pretty much parallel to each other. The main difference between the arteries and the nerves that you'll probably need to know is that on the arteries, the maxillary artery supplies or branches off to supply blood to most of the areas of the oral cavity. So unlike the nerves where you have a maxillary division and a mandibular division, when at the arteries, the maxillary, like the inferior alveolar artery, branches off of the maxillary artery. Where on the nerves, the inferior alveolar branches off of the mandibular. I know that's pretty confusing, and they like to kind of throw those confusing questions in. So they look for those exceptions. When it comes to arteries, the maxillary artery is the main one. When it comes to the nerves, you've got the three divisions, the V1, the V2, and the V3. The V2 supplying innervation to the maxillary, and V3 supplying innervation to the mandibular. The pterygoid plexus of veins is the one that you can accidentally inject to when you're doing your PSA. Part of it sits in the infratemporal fossa. Any questions on that? Okay. Let's see. Dental anatomy. So we'll go through some dental anatomy stuff now. Do you want to take a break before we jump into dental anatomy? Anybody? Yes? No? Okay.
I think we can keep going.
Okay, let's keep going. So as far as dental anatomy, some terminology you'll need to know. Line angles. Line angles are like the corner of the room. They separate two surfaces of the teeth. So a line angle would be like the mesiolingual. Where the mesial and the lingual meet, it's going to be like the corner of a room. Those are line angles. So think of your teeth as like a cube with exact corners on them instead of a rounded, more rounded surface. And your line angles are going to be where the two surfaces meet. So like your mesial and your distal are never going to meet, but your mesial and your buccal can form a lining. Point angles are where three surfaces meet. So you might have your mesial surface, your buccal surface, and your occlusal surface all meet. So it's kind of like where the two walls and the roof meet. And that's a point angle right there. Lobes. Lobes are like growth centers for development. So parts of the teeth develop from the lobes. You're going to usually have 4 or more lobes on a tooth. Anterior teeth and premolars have 3 lobes on the facial surface, and then 1 lobe on the lingual, with the exception of your mandibular second premolars. If they have 2 lingual cusps, they're going to have 2 lobes on the lingual side. Developmental grooves separate the lobes. So the lobes kind of, think of the lobes sticking out and being like a ripple, and the developmental grooves separate them. Fossas are depressions. So think of like when we talked about some of the fossas on the head, they were just like indentations or depressions. Cusps are mountains, and they're on occlusal surfaces. Ridges are elevated portions of a tooth that run in a line. So think of your triangular ridges. They were the elevated portion of the tooth. So we followed the ridge from the cusp tip down to the center, and it was that elevated part of the cusp. Marginal ridges form the borders. So think of your margins on a piece of paper. Your margins on a piece of paper define the sides of the piece of paper. So you've got your left margin and your right margin. In teeth cases, you have your mesial margin and your distal margin when it comes to posterior teeth. When you're talking about anterior teeth, your marginal ridges are on the lingual surface. So you would have a mesial and a distal, but they're on the lingual surface. So they come from the cingulum to the incisal edge, or they form like an arch. Triangular ridges run from the tip of the cusp to the center part of the tooth. And then a transverse ridge is formed by 2 marginal ridges. So you've got a cusp marginal ridge coming down this way. You've got one coming this way. Think of them like skateboarding ramps. You've got one ramp here, one ramp here. The transverse ridge would be if you went from the cusp tip to the cusp tip. You've got oblique ridges. So your oblique ridge runs across obliquely or diagonally across the tooth. It runs from the distal buccal to the mesiolingual. And then we've got the cingulum. The cingulum is that little bulge on the back of your anterior teeth that you can feel with your tongue. The cingulum forms from a lobe. You've got a lingual groove that separates lingual cusps. You've got a central groove that runs down the center of the tooth. Then your clinical crown and your anatomic crown. So your clinical crown is the part of the crown that you can see. Your anatomic crown would be the part that's covered with enamel. So your clinical crown may include part of your root if you are looking at a tooth that has a recession on it. And then you have your clinical root, which is the unerupted part of the root, and your anatomic root is the entire root below the CEJ. So that's where you might have differences, is when you have gingival enlargement or gingival recession, because that changes the clinical root and crown. Anatomic root and crown stay the same. So the part that's covered with enamel is going to stay the same, regardless of the position of the tissue. It's the clinical part that changes depending on the changes in the tissue. Then you have your cementum, your four parts of your tooth, your cementum, your dentin, your enamel, and your pulp. So your cementum is the part that covers the root of the tooth. It's most similar to bone. It's 65% inorganic, 35% organic. And it's thicker at the apex. It's thinner at the CEJ. And it has more irregularities at the CEJ. Your dentin forms the largest part of the tooth. It's underneath the crown or the enamel of the crown, and it's also underneath the cementum of the tooth, of the root. It's 70% inorganic, 30% organic. Your dentin continues to form after the tooth is erupted. So your dentin kind of turns itself over. It's called reparative dentin. It's in response to trauma. Let's see. If the dentinal tubules are exposed, you can have hypersensitivity or sensitive teeth. The enamel is formed by amealoblasts, and it's 96% inorganic and 4% organic. And your enamel is thickest near the crown tips and thinnest at the CEJ. And then you have your pulp. Your pulp contains your nerves, your blood, your lymph vessels. It contains the nourishment to the tooth. If it's stimulated, it can cause pain because it's got the nerve supply. The pulp chamber can vary in size based on the age, the function of the tooth, and trauma. So the contours of the teeth, play an important role because they determine how effective your teeth are at deflecting food off of them. The height of contour or crest of curvature, they're used interchangeably. The height of contour is the greatest elevation or the biggest bulge on a tooth. So the buccal height of contour on an anterior tooth is greatest in the cervical third. The buccal height of contour on a posterior tooth is greater in the cervical third. So all teeth, the buccal height of contour is in the cervical third, or in other words, closer to the gum line. The lingual height of contour, or crest of curvature, of posterior teeth is in the middle third, and anterior teeth is the cervical third. So if you think about an anterior tooth, if you're not sure, take your tongue and touch your tongue on your anterior teeth. The cingulum makes it thicker or thickest at the gum line. So the greatest bulge on the lingual part of an anterior tooth is at the cervical third along the gum line. On posterior teeth, it's in the middle third. And that makes scaling a little bit more complicated because the tooth kind of bulges out in the middle, but then it comes back in a little bit at the gum line. So when you're placing your scalers, you have to get around that bulge so you can get all the way against the tooth at the gum line to scale. And then the curvature of the CEJ, is it greater on the mesial or the distal? If you're looking at the mesial and the distal of a tooth, is the curvature greater on the mesial or the distal? Do you guys remember that? Anybody want to take a guess? You have a 50-50 chance.
Mesial.
Yep, it's mesial. It's greater on the mesial. So your embrasure spaces, you have embrasure spaces. Your embrasure spaces are filled with your interdental papilla. But when you're looking at just teeth, they're called embrasure spaces. And your embrasures are also called spillways. They're located between the occlusal surface to the contact area of the tooth. And then they're also from the occlusal surface, the contact area to the bone. They prevent food traps when they haven't the interdental papilla in them. Maxillary teeth, permanent dentition, central incisors, you will have to know your eruption pattern. So your central incisors erupt at 7 to 8 years old on the maxillary. They come shortly after the mandibular. The mandibular central incisors are the first to erupt on a permanent dentition. The maxillary central incisors erupt at about 7 to 8 years of age. They are the most prominent teeth in your mouth. So you see them the most when you smile. They're the widest from the mesial to the distal. So if you look at them, they're the widest teeth of your anterior teeth. Let me rephrase that. I know that sounded confusing. Of your anterior teeth, they are the widest. The cross section of the root is round. So in other words, if you took the root and you cut it like this, it would be nice and round. They have a cingulum. The next step is your lateral incisor. Your maxillary lateral incisors erupt between 8 and 9 years of age. They can have a lot of variation in their form. They have a prominent lingual pit. So that's something to remember about them. So they have the cingulum, and the cingulum comes up or comes around, and it's got a little lingual pit on it. And that pit can be prone to decay. It also has a developmental groove that goes up the root on the lingual surface, and that can make for scaling a root planing a little bit more complicated. They look just like a central incisor, but they're smaller. As far as their anomaly, they can be peg. You can have something called a peg lateral, or they're also congenitally missing. Commonly, that is a genetic or congenitally missing. You can trace that in families. The canines, the maxillary canines erupt around 12 years of age. They're the longest tooth in the mouth and the longest root in the mouth. They're anchor teeth, and they have a very well-developed cingulum. The cingulum separates the back side or the fossa into two separate fossas. So the cingulum on it comes down far enough that it splits the lingual surface into two separate fossa, a mesial and a distal. I've seen that in other board review tests and stuff like that, so I would imagine that's something that boards is kind of big on. Your maxillary first premolars. So the interesting thing to remember about your maxillary first premolars is they can have the bifurcated root. And when they do, it's a buccal and a lingual. So unlike a mandibular molar that has them like this, they sit like this, buccal and lingual. They also can have that deep mesial root groove that's prone to periodontal disease. It's difficult to scale. They can have 2 pulp canals. On the actual crown surface of the tooth, they also have an indentation or a depression on the mesial side of the crown. And they also have an anomaly that they have is that their mesial margin or their central groove crosses over the mesial marginal ridge and runs down the mesial side of the tooth. So if you were looking at it from an occlusal view, you would see the central groove continue on and go over the mesial marginal ridge and down onto the mesial side of the tooth. That's another thing that they kind of like to talk about in boards. The second premolar erupts around 12 years of age, and it's smaller than the first premolar. It has only 1 root. It's a boring tooth. The cusps are about the same length. Then you have your maxillary first molar. Your maxillary first molar erupts at about 6 to 7 years of age. It's the largest tooth in your mouth. Maxillary first molar. It has 5 cusps, if you count the cusp of Carabelli, which is located on the mesiolingual cusp. It has a prominent oblique ridge, so the ridge that runs diagonally. The distal lingual developmental groove or the distal oblique groove extend from between the 2 lingual cusps and curve sharply to the distal side. So it's just got an odd developmental groove on it. It has 3 roots, with the palatal being the largest, the mesial buccal root being the second largest, and the distal buccal root being the smallest. It's very difficult to root plane. Then we have our maxillary second molar, which erupts at about 13 years of age, 12 to 13 years of age. It's smaller. All of the cusps are smaller than the first molar, so it's overall a smaller tooth. It has an oblique ridge, but it's not as prominent as the first molar. It also has 3 roots, the palatal being the largest, and then the mesiobuccal second largest, distal buccal smallest. And the unique thing about it is it may be missing a distal lingual cusp. So sometimes it only has 3 cusps, a mesiobuccal, a distal buccal, and then a lingual cusp. When it is missing the distal lingual cusp, it's kind of heart-shaped. Then you have your maxillary third molar, which is your wisdom tooth. It erupts anywhere between 17 and 25 years of age. They can vary in shape and size. There's no real rhyme or reason to it. It usually does not have a distal lingual cusp, so making it heart-shaped. So it can often times be mistaken as the second molar. It's usually smaller though. So before we go to the mandibular teeth, let's take a little break here and come back at about 2 o'clock. Sound good?
Yes.
Thank
that's fine.
you.
All right.
Oh, hey, Jenna, I know you're in here.
Hey. Okay. Are you guys still there?
Yep.
All right.
Yep.
Good. So I'm sitting here in the classroom in 511 and it is freezing, so I ran and got my coat. Man, there's no movement in here, so it's really cold. Okay, so let's talk about the mandibular teeth. We have our central incisors. They erupt between 6 and 7 years of age. They're the smallest teeth in the mouth. They only have one antagonist. In other words, they only occlude with one other tooth. And they are bilaterally symmetrical. So if you cut them in half, they look the same on the mesial side as the distal side. Then we have our mandibular lateral incisors, which erupt between 7 and 8 years of age, and they look similar to a central incisor, but they are larger, and they have a more rounded distal, and they tend to turn slightly toward the distal, so they are slightly curved as far as the tooth itself, toward the distal. Then we have the canine. The canine, mandibular canines erupt between 9 and 10 years of age, so a lot sooner than the maxillary canines. They're the longest tooth in the mandibular arch. They have no lingual pits, so their lingual surface is much smoother than the maxillary. So the maxillary, you have that, you have the fossa, or I should say the cingulum divides the fossa into two smaller fossas. And the mandibular is not like that. It's smooth on the lingual. And it may be bifurcated. It's not common, but it may be bifurcated. And we've got the mandibular first premolar. The mandibular first premolar looks really unique. It erupts around the 10 to 12 years of age. It's smaller than the second premolar. It has two cusps, and the buccal cusp is much larger than the lingual cusp. The lingual cusp is small and is afunctional, or it does not function. So it has that big kind of arched over look. And then it's got a mesial lingual developmental groove that separates the mesial marginal ridge from the lingual cusp. So if you're looking at it from the lingual or from the mesial, you can see this mesial lingual groove that comes down. And it's unique to that tooth. It looks and functions almost more like a canine than it does a premolar. Your mandibular second premolars are kind of complicated. They erupt around 11 to 12 years of age. They're larger than the first premolars. They can have either 2 or 3 cusps. If they have 3 cusps, 2 of them are on the lingual and 1 is on the buccal. If they have 3 cusps, they will have a lingual groove. So anytime you have cusps, you're going to have a groove that separates the cusp. So if you have 2 lingual cusps on the mandibular second premolar, they're going to have a lingual groove. The shapes, or I guess it would be the shapes of the occlusal surfaces can be either a U, an H, or a Y form. The U form goes with the first premolar, so the lingual or the occlusal table forms like a U. And then the H form and the Y form go with the second premolar that has 3 cusps. So the Y, the bottom part of the Y goes like that. The bottom part is the lingual groove. So it forms that same shape like this, but it has that lingual groove, so it forms a Y. The mandibular first molar erupts at about 6 to 7 years of age as well. It has 4 major cusps and 1 minor cusp. So it has the mesial buccal, mesial lingual, distal buccal, distal lingual, and then it has a small distal cusp. So we basically say it has 5 cusps. It's the largest tooth in the mandibular arch. Let's see. The distal root is shorter and has a longitudinal groove. Then we've got the mandibular second molars. They erupt between 12 and 13 years of age, like all the second molars. They only have 4 cusps. They form a T on the occlusal table. So the cusps are almost appear equal in size. So therefore it forms like a nice even T. So think of your amalgam restorations that you've seen that look like little T's. That's classic to the mandibular second molar. The roots are shorter, closer together, and the mesial root can have 1 or 2 root canals on it. And then you've got your mandibular third molar or wisdom tooth. They erupt around 17 to 25 years of age. They, like the maxillary, can have all kinds of shapes to them. They can have a lot of supplemental grooves on them, on the occlusal surfaces. Their crowns tend to be smaller, though, than the other molars. Then we have our primary dentition. Any questions about the permanent dentition?
Nope.
Okay. Then we have our primary dentition. You're going to have to know the eruptions of the primary dentition. So know the eruption patterns and dates of the permanent, know the eruption patterns and dates of the primary. The questions or the stuff that you're going to get on those teeth is likely going to be more like a case study, and they'll have like a radiograph, a pano or something, and there'll be a mixed dentition on it. And based on the teeth that you see and what you know about the eruptions, you should probably be able to kind of decide how old that patient is, or they might give you the age of the patient, and you're supposed to kind of know what teeth they should have. Sort of like if you were in clinic or in a private practice and a patient opens their mouth, a child, you should be able to look in their mouth and identify which ones are their primary teeth and which ones are their permanent teeth. And the first clue you're going to go off of is how old is the child. And so, you know, if they're 6 years old versus 9 years old, you're going to see different, you should expect to see different teeth just based on the fact that their age. So they erupt in, as far as their pattern of eruption, you've got your centrals, your laterals, so mandibular centrals, maxillary centrals, or the mandibular laterals come in about the same time, and then your maxillary laterals come in last. And then there's a little break there for a while, so the baby will have 8 teeth, 4 on the top, 4 on the bottom. Then along come the first molars. So the mandibular first molars come first, then the maxillary first molars. Then the canines come in. So you've got the mandibular canines, the maxillary canines, and then you've got the mandibular second molars and the maxillary second molars. So overall, for the most part, the mandibular teeth come in before the maxillary of the same tooth. The mandibular centrals will be before maxillary, mandibular laterals before maxillary. So the mandibulars come in first. So commonly extracted teeth for ortho are going to be the first premolars, but not always. And they would be teeth number 5, 12, 21, and 28. So you might commonly see that. You already know the universal numbering system. Just refresh your memory on the Palmer and the the international system. The Palmer system goes 1 through 8 in each quadrant. Back, this is quadrant 1, 2, 3, and 4. The international system puts a 1 in front of it if it's in quadrant 1, and then the tooth after that. So like the upper right canine would be 1, 3. The upper right second premolar would be 1, 5. If it was on the left side, it would be 2 and then 1 through 8. Down here, it would be 3 and then 1 through 8. And down here, it would be 4 and then 1 through 8. I don't know if they'll have questions on that, but as far as terminology, so your overjet. Your overjet is how much horizontal overlap of the maxillary teeth. So how far do they jet out? That's the way I always think of it. They jet forward. Your overbite is how far down do they go? How much far over does the top bite over the bottom? Your crossbite is when one or more teeth of the mandibular arch are facial or are out further than the maxillary arch. So the maxillary teeth should always be out further. If the mandibular are out, that's called a crossbite. Open bite is when the teeth don't touch each other in occlusion. End to end is used to describe when posterior teeth are biting on top of each other. Edge to edge is when the anterior are biting together. And when when the teeth are in a position of rest, they are not in occlusion. So in other words, if your teeth and jaws are in a position of rest, the mouth is slightly opened. Exostosis, we know, are the bony overgrowths on the buccal surfaces. Tori or torus. Tori are the two down in the lower lingual. The torus is the one up on top. Enamel hypocalcifications are when enamel does not become calcified. They look like little white areas on the teeth. You've seen that a lot. Versus enamel fluorosis, which is the most common form of hypocalcification. So you can call it enamel fluorosis. And we've all seen lots of that on our patients in the clinic. Let's see. Supernumerary teeth. Supernumerary teeth are basically an extra tooth. Succedaneous teeth, going back to supernumerary, sorry. The most common are the maxillary molar area, and then and also the mandibular premolar area. Then we've got succedaneous teeth, permanent teeth with primary predecessors and include the anterior teeth and premolars. The succedaneous teeth are teeth that come in after a tooth fell out. So in other words, your incisors, your canines, and your premolars. Your non-succedaneous are teeth that came in without having another tooth come out, like your molars. Exfoliation are when the roots of deciduous teeth are resorbed. And then extrusion is the supereruption of a tooth. Avulsion occurs when the complete displacement of a tooth occurs due to extensive trauma. So a tooth gets knocked out. A diastema is a space between the teeth. Usually it's at the midline. Attrition is the wearing away of tooth by functioning. So two teeth rubbing together, attrition. Erosion is usually by a chemical like an acid, like somebody sucks on lemons and the acid erodes their teeth. And abrasion is usually by a mechanical force like a toothbrush. So you cause toothbrush abrasion, aggressive toothbrushing. Then we've got caries classifications. So class 1, pit and fissures. So those are on the occlusal surfaces of molars and premolars, or the lingual of the maxillary lateral incisors, where you have that little pit. Class 2 are proximal surfaces of premolars and molars. Class 3 are proximals of incisors and canines, but don't involve the incisal edge. Class 4 are the proximals of incisors and canines and involve the incisal edge. Some of these are seen through radiographs. Some of them are seen through transillumination. Some of them are seen through direct vision. Class 5 are on the cervical third. You tend to see class 5 decay more commonly on patients that have recession. And then class 6 are on the cusps or the incisals of anterior teeth. Does anybody have any questions about dental anatomy? I think we should all probably feel pretty comfortable about looking at dental anatomy and knowing what we're looking at. But does anybody have any questions or anything? I do have a couple of handouts that I can give or ask Professor Trester to post if on your campus site that might help you for studying. All right, so next up is going to be perio. Just make sure I covered everything on anatomy before we move on to perio. Yes, so we're going to move on to perio now. So as far as perio goes, perio is going to include some of your microbiology stuff. So I don't know if Professor Trestner gave you kind of like a breakdown of like how many questions are in each category. Do you guys have anything like that? Like how many perio questions, how many micro questions are on boards?
I don't think so. I don't remember seeing that.
Okay, so sometimes you can like look it up and you can see like it'll say that there's 35 questions on perio and 15 questions on micro, and they'll have half the questions are on case studies. Well, they all cross over each other at some point. So you will want to make sure that you look at your gen ed stuff for micro and make sure that you just look at the basic stuff. What are the basic shapes of the bacteria? How do they stain? I kind of grabbed a few things that I could find that sort of review that, but you'll probably want to go through the micro section of like the Dental Dex or Quizlet and find some micro stuff and kind of reinforce. I saw like questions about disruption of the cell wall, like bactericidals and bactericidals and statics and which one disrupts the cell wall and all that kind of stuff. So you might want to review some of that stuff. That's going to be in infection control. That's going to be in micro. So again, they all kind of cross over each other. So you might want to just brush up on some of your general micro stuff before you dive into some of these other things. As far as the bacterial morphology, you've got your cocci, which are like your strep. Commonly, they're round in their shape. They can link to each other, but they look like a chain of round balls hooked together. You've got your bacilli. Bacilli were the ones that were kind of like cylindrical in shape or look like the Cheetos. You've got your fusiform, which were thread-like, look like spaghetti. Your spirochetes, your filamentous bacteria or rods, and then you've got your vibrios, which were like shaped like commas. Their appendages, you've got flagella and pili. Your flagella are for motility or movement. Your pili are for attachment. So they help the bacteria move and attach themselves. You've got the capsule, which forms on the outside of a lot of different types of bacteria. It protects them from dangers like drugs or mouth rinses and things like that that can invade the cell and kill it, the bacterial cells, and kill them. So the capsule helps keep those things out. You've got your oxygen environments. So you've got the oxygen influences bacteria's ability to grow or to multiply. You've got your aerobes, which are bacteria that require oxygen. You've got your anaerobes, which live or grow in the absence of oxygen. Your facultative anaerobes, which live in the presence or absence of oxygen, so they're kind of right in between. And your obligate anaerobes cannot survive in an oxygenated environment. Let's see. as far as like cell staining, the structure of the wall determines that. So as far as staining goes, you've got gram-positive bacteria retain a purple stain. So the outer surface component is the cap of the capsule is a polysaccharide. And then you've got your negative stain, gram-negative bacteria that stain red. And their outer membrane is composed of receptor proteins that in adherence and complex lipopolysaccharides. So they have endotoxins or LPSs or lipopolysaccharides. I don't know if you remember those terms, that release when the cell wall is disrupted. And that disruptive mechanism or release is what triggers your host response. So your common periodontal bacteria, you will really need to know your bacteria. There are quite a few questions about the types of bacteria on boards. So you'll need to know your cocci, you'll need to know your strep bacteria and your staph bacteria. Your cocci are mostly your strep bacteria. They're what we call the good bacteria. Then you've got your rods that are also in your gram-positives. Your gram-positives are your better bacteria. They, if they stay populated, they help keep the gram-negative in a balance. Your gram-negative bacteria are your more powerful. They contain like your AA or can't even say them. Agrigentobacter, actinomyceticins or something like that, the AAs. And so they also contain like your P. gingivalis, your P. intermedia, your Tannerella, Fusobacterium. So those are all your more gram-negative, powerful bacteria found in periodontal disease. Remember your P. gingivalis and your P. intermedia. Those are big periodontal bacteria. You've got spirochetes like Treponema that are big. I have a list of gram-positive and gram-negative bacteria. So your gram-positives contain your staph and your strep. Your strep mutans, strep salivarius, and strep sanguinis are your most common ones. Your lactobacillus and Actinomyces, I don't even know how to say these, Actinomyces israeli are all common gram-positive bacteria. Then you've got your gram-negative, your Porphyromonas gingivalis, Prevotella intermedia, AA, Treponema. So those are your bad bacteria. More found in periodontitis. So just basic, so that's basic micro. Go back to your basic micro and refresh your memory on that. In your textbook, your perio textbook, there's a list. I gave you a handout, a list of bacteria. I'm sure they're listed in your board review books. So just make sure you study the bacteria fairly well. So overall perio. So let's start with your periodontium. You've got your gingiva. You've got oral epithelium or your outer gingival epithelium. Your oral epithelium's function is to protect. It protects the underlying structures. It's keratinized or parakeratinized. The more keratinized the tissue is, the more tough it is. So like your most keratinized tissue on you is like on your hard palate, the palms of your hands, the soles of your feet. It's very keratinized tissue. It's very, very sturdy, very strong. It's waterproof tissue. Keratinized tissue has no nuclei. Then you've got your sulcular epithelium. Your sulcular epithelium is found inside the sulcus. Your sulcular epithelium is an extension of your oral epithelium. It's non-keratinized. In other words, it's very soft. It's not that hard keratinized tissue. Your sulcular epithelium starts at your gingival margin and it runs inside your pocket or your sulcus to the junctional epithelium. Your junctional epithelium is the base of your gingival sulcus. So you're sticking your probe in, and on one side, when you slide your probe in, one side's the tooth, the other side's the sulcular epithelium, and your tip of your probe is going to stop at your junctional epithelium. Your junctional epithelium separates the PDL, or periodontal ligaments, from the oral environment. So the job of your junctional epithelium is to protect your periodontal ligament and your underlying alveolar bone from your oral environment, or in other words, from the bacterial invasion of the bacteria that are floating around in your pockets. They are thicker at the coronal portion. The junctional epithelium is thicker at the coronal portion. It's only a few cells thick as you go down apically. And then you've got your gingival connective tissue. Your connective tissue beneath the gingiva is called the lamina propria. I don't know if you remember that term. Don't get it mixed up with your lamina dura. Your lamina propria is collagen. It's connective tissue. It's formed into fiber bundles. There are 5 principal fibers of the gingiva. This is probably starting to come back to you. The ones to know, the more important ones to know, are the circular and the transeptal. The circular circle around the tooth, and they support the free gingiva. They hold the free gingiva up around the tooth. If they didn't hold the free gingiva up, the free gingiva would get damaged through like mastication or grinding. Your transeptal fibers run from tooth to tooth. They connect cementum to cementum, so they are what kind of helps hold the teeth in alignment. The transeptal fibers are the ones that also give orthodontists a lot of grief when they want to move a tooth and the fibers keep pulling it back the direction it came from. So they run from cementum to cementum. Those are the ones that they're probably going to ask you about, are those. Your periodontal ligament fibers. You had 5 principal fiber bundles of the periodontal ligament. Your alveolar crest ones. Those are the first fibers that are affected by periodontal disease. So think about where periodontal disease starts. It starts by eating away at the lamina dura in the alveolar crest. So right at the corner is where it starts to nibble, right up in the corner, and it kind of starts to round out or flatten out those corners as it continues to eat on through the alveolar crest. So those fibers get destroyed first. Then you've got your horizontal fibers, your oblique fibers, and your apical fibers, which help support the tooth in the socket. The oblique fibers are the most in number, so you've got more of them. And then you've got your intravesicular, which are only found on multi-rooted teeth because they're in the furcation area. And they kind of hold or attach the tooth in the furcation area to the alveolar bone that comes up between the roots of the teeth. Anybody have any questions on those? Okay. You've got your cementum. So your cementum is calcified tissue that covers the tooth from the CEJ to the apex. There's an opening at the apex of the tooth called the apical foramen. The apical foramen is where the nerves and the blood supply and the nutrients and the lymph pass through the tooth. It runs up through into the pulp of the tooth. So the apex is actually open on the tooth. The cementum is where the Sharpie's fibers attach. So the Sharpie's fibers are the little brush-like fibers that are on the end of the periodontal ligament. So you've got your thin little periodontal ligament, and then you've got these fibers coming off the sides. The fibers attach on one side to the alveolar bone and on the other side to cementum. So they are the ones that keep the periodontal ligament fibers attached, are the Sharpie's fibers. The cementum does not have any nerve supply or any sensitivity to it. So all of your sensitivity to your teeth comes from the actual pulp of the tooth itself. Well, here's my notes on the lymph nodes. So how they got mixed in with the... Okay, then we've got the alveolar process. So the alveolar process is the support system for the teeth. The function of the alveolar process is to support and provide attachment for the periodontal ligament fibers. So you've got different types of bone. Remember, we had cortical bone, compact bone, our cortical bone, cancellous bone, the cribriform plate. We've got the alveolar crest, the lamina dura. So all different types of bone. The cortical plates, or the hard supporting outer cortical bone, is important because it's on the buccal and the lingual surfaces. It supports the inner side of the bone. The inner bone, the cancellous bone, is more porous. So it's not as sturdy as the compact bone. We have the cortical plates, or what we call cortical plates, are in the buccal and the lingual. Those are the bone that we have to be careful that we don't make it too thin. If we move the teeth orthodontically more to the buccal, we thin the bone on the cortical plate. So when you're orthodontically moving teeth, what you're doing is you're pushing or putting pressure on the bone where you want the tooth to go. And so the bone is resorbing so that the tooth can go there. And then right behind it, your osteoblasts are building bone behind it to keep the tooth there. And that process takes a lot of time, and that's why it takes so long for teeth to be moved during orthodontic treatment. So, but if you go too much into the cortical bone or cortical plates, you can have problems with recession and things like that. So going back to bacteria now. So how does the bacteria get on the teeth? Do you remember the acquired pellicle, the pellicle that forms first? So pellicle forms on the teeth. Pellicle is actually glycoproteins. It's not bacteria. It forms on the freshly cleaned tooth. So you get your teeth polished at the dentist, and they're all nice and clean and smooth. And then this layer of glycoprotein forms immediately afterward. So it kind of like seals off the tooth. The pellicle also acts as a foundation for bacterial colonization. So the pellicle itself is made out of glycoproteins. It is not bacteria, but it allows for the adherence of bacteria. So the purpose, or the other thing that pellicle does, is it provides a seal or a barrier against acid. So it helps to prevent caries. But it also acts as a mode for plaque and calculus retention. That's the good news and the bad news. It's like saliva. It has a good purpose and it has a bad purpose. So then once the pellicle is formed on the teeth, it allows for bacteria to colonize. And so as far as bacterial attachment, so you've got your gram-positive bacteria that colonize first, and they stick to pellicle. And then if they're not disrupted, then the bacteria start to link together and they start to grow thicker. And then they start to become more switching to gram-negative or more potent bacteria. And at some point, they don't allow any more positive. They kill off or cause the positive bacteria, gram-positive, to go away. And it's mostly gram-negative that are on the tooth surface. Let's see, the stages, the initial stage of plaque formation is the bacteria colonize, they multiply, and they mature. So they find themselves set up a tent on your tooth, and then they go ahead and they multiply and they get older and bigger and more mature. Plaque starts to mature in days 1 to 2. It's still immature plaque. Days 2 to 4, it becomes more dominant in cocci. As they go into days 4 to 7, they start to change and the flora becomes mixed, or you start getting some rods and other types of bacteria. Days 7 through 14 are when your more gram-negative anaerobic bacteria start to set in. Days 7 to 14 are when you first have signs of visible inflammation. So you might start to see some papillary redness and then perhaps some marginal redness. Inflammation starts in the papilla and moves to the margin and then down into the attached gingiva. Days 14 through 21 is gingivitis. So you have mature plaque by that time, and gingivitis is clinically evident. So you'll get bleeding on probing, inflammation, change in color, change in contour. So all those things by 14 to 21 days after the bacteria have attached themselves, if they are not disrupted, to form gingivitis. Subgingival plaque versus supra. Subgingival plaque is below the gum line, supra is above. Subgingival plaque has more gram-negative anaerobic bacteria than supragingival. Let's see. Materia alba. Materia alba is the cottage cheese looking masses. So materia alba can be easily removed. If you blow air and water on it, it can be removed. Where plaque, once it's colonized, is not easily removed. Subgingival plaque has more anaerobic bacteria. It has more vibrios, spirochetes, fusobacteria than supragingival. Mineralized plaque becomes calculus. So you have these groups of organisms that now become calculus. Mineralization begins in 24 to 48 hours. And then the average time is 12 days, 12 to 14 days for plaque to become completely mineralized to calculus. If it forms within about 10 days, you're considered a rapid calculus former. Anything longer than that, like around 20 days, is considered slow. Supragingival calculus is yellow or sure white. Subgingival is usually dark green or black. And that's because of the blood pigmentation, or the blood, red blood cells it picks up when it's from the tissue when it's up. The most common areas to get supragingival calculus are in the mandibular anterior teeth on the lingual, or the buccal surfaces of the maxillary molars, and that's due to the salivary gland. So the attachment mechanism, you first got your adherence to pellicle. So first, the bacteria have to adhere to pellicle. At that point, they can still easily be removed with good oral hygiene. If they are not removed, they kind of penetrate into the matrix of the cementum and are much harder to remove. At that point, they usually have to be removed. That's when people get their teeth cleaned. If they are still not removed, then the endotoxins in the pocket will cause apical migration of the junctional epithelium, exposure of cementum. You get necrotic cementum, irregularities in cementum from that. And so with that, calculus forms even a tighter bond. So the mode of attachment, or how strong the attachment is, determines how hard you have to scale and root plane. So I know some of you have seen these patients in clinic where you've used every tool imaginable and you still cannot get the calculus off. I mean, that calculus has built itself a home inside the cementum. And it's become very necrotic and it's very tightly bound in there and interlocked within the cementum. And so it's very difficult to remove at that point. Oftentimes, the tissue has to be flapped and the layer of cementum actually removed with like a burr to get that all completely off. Toothpaste, pyrophosphates in toothpaste are what gives it a tartar control ability. So tartar control toothpaste contain pyrophosphates. They bond with the plaque in an effort to keep them from being able to form into calculus. So it stays at a less mature state. Note that pyrophosphates in toothpaste or tartar control toothpaste will only help prevent additional tartar buildup. They do not remove tartar that's already formed on the teeth, and they only help supragingival. They don't do anything for subgingival. Gingivitis is an inflammation of the gingiva. There's no apical migration of the junctional epithelium and no bone loss associated with gingivitis. You can have bleeding on probing, changes in color, consistency, etc., but no actual clinical attachment loss is associated with gingivitis. In the initial stages of gingivitis, you have plaque bacteria forming. You have an immune response to the plaque bacteria, and so you start to get PMNs or polymorphonucleic cells that migrate to the area, T lymphocytes. So some of your inflammatory cells start. In the initial phase, you have no clinical signs. So these things are going on below the surface of the tissue, but there are no actual clinical signs. So if the patient came into your office to have their teeth cleaned at that point, you would not see any signs of anything looking unusual. Early gingivitis is when the tissue starts to turn red, stippling disappears, there's signs of inflammation, there's bleeding on probing, the tissue becomes shiny, your lymphocytes increase underneath the surface, collagen starts to be destroyed, fibroblasts are destroyed, so fibroblasts build collagen fibers and they get destroyed. So now at this point in time, you start to have some actual clinical signs. Established gingivitis, your gingiva continues to get red. You've got capillary proliferation, bleeding on probing depths start to increase, plasma cells infiltrate, the reedy pegs extend into the connective tissue. Then we've got pockets. So we've got different kinds of pockets. We've got a true pocket. A true periodontal pocket is a pathologic deepening of the sulcus due to the apical migration of the junctional epithelium. So you actually have to have the junctional epithelium migrating down the surface of the root or down the cementum surface. Then you've got your pseudopockets. Pseudopockets are the deepening of the gingival sulcus due to the coronal migration of the gingival margin. In other words, inflammation has caused the tissue to swell upward, but the attachment is still in the exact place it should be. You've got suprabony pockets. So suprabony pockets are where the depth of the pocket or the junctional epithelium is attached above the crest of the alveolar bone. This is mostly noted with horizontal bone loss. And then you've got infrabony pockets where the junctional epithelium has migrated below the crest of the alveolar bone. And this is usually associated with vertical bone loss. You've got bony defects. So we have different types of bony defects. We've got so remember, the bony defects are opposite of what seems like it would make sense to you. So the more wall defect you have, the better the prognosis for the tooth. In other words, if you have a 3-wall defect, what that means is that you still have 3 walls of bone intact. So you may have lost bone on the mesial side of the tooth, but the buccal, the lingual, and the distal are all still intact. So that's got the best prognosis because you still have 3 of your 4 walls intact. A 1-wall defect, on the other hand, means that you only have 1 wall left intact. So that one has the worst prognosis. So in other words, if you have 1 wall left intact, you could have destruction of the mesial, the buccal, and the lingual, and all you have left is the distal wall. So that's not very much support for a tooth that's left. So that tooth would have a poor prognosis. Classification of periodontal diseases, gingival diseases. So we've got the new classification system. So you will need to know the new periodontal classification system, but you will also need to know some of these other classification systems that they still use out in practice. So we've got gingivitis, which is plaque-induced gingival disease. So we've got gingivitis that's associated with dental plaque only. It's the most common form of gingivitis, plaque-induced gingivitis. It's directly related to bacteria on the tooth surfaces. Then you've got all these other things. You've got gingival diseases modified by systemic factors. So you've got a systemic factor that is going to change the way your host's immune system reacts. But the systemic condition is not the cause of the gingivitis. It can modify the gingivitis or the path of the gingivitis or modify the extent of the gingivitis, but it does not cause gingivitis. Then we have endocrine influenced gingival diseases. Those are associated with puberty, pregnancy, birth control. Again, they are they're caused by bacteria and plaque, but your host response might be altered due to these other disease or other conditions, such as puberty, pregnancy, hormones, that kind of thing. Gingival disease is modified by medications. You can have medications that cause gingival hyperplasia or overgrowth. So they change the contour of the gingiva, which causes plaque to accumulate. So again, the common theme here with all of these is that it's the plaque accumulation that's causing the gingivitis. You have gingival diseases modified by nutrition, so you can have some nutritional deficiencies such as vitamin C, which modify your response to plaque. Does anybody have any questions about those? So plaque-induced gingival diseases are going to be more common. If you think about your chart that you use in clinic now with the new classification system, you have gingival health, and then you have gingival diseases and conditions, and you have plaque-induced gingivitis, and then non-plaque-induced gingivitis. So most of your patients that don't have periodontitis are going to fall either into health or plaque-induced gingivitis. The non-plaque-induced gingivitis are more rare. What we usually would say is go with the assumption that the gingivitis is caused by plaque unless you find evidence that tells you that the gingivitis is something other than plaque-induced. So you can have non-plaque-induced gingival diseases. And so gingival diseases of a specific bacterial origin would be one of them, such as NUG. NUG is a very specific type of bacteria. It's bacteria that are not found in normal gingivitis. Usually fusiform bacillus and spirochetes are found. Both of those are not common organisms in just regular gingivitis. NUG is characterized by, it's brought on by stress and characterized by the appearance of cratered or punched out papilla. So in other words, the papilla like dip in the middle. A pseudomembrane or a fake membrane. So you it looks like there's tissue or a membrane over the top of the tissue. And if you rub it, it wants to rub off. And then you've got an odor. So NUG has a terrible odor. So basically, stress, punched out papilla, pseudomembrane, and odor. It's usually brought on by fusiform bacillus and spirochetes. Then you can have gingival diseases of viral origin, the main one being primary herpetic gingivostomatitis. So basically a herpes outbreak. It's not technically a gingival disease, but you can have elevated temperature, or like fever, malaise, you can be tired, vesicle formation or ulcerated lesions on the gingiva or mucosa. So commonly you'll see a patient come in and they've had a dental treatment done. Maybe it's been scaling and root planing. Maybe it's been a bridge prep. And they come back in and they have these little vesicles in the area. And that's a sign that they have gotten primary herpetic gingivostomatitis. We don't work on patients that have a herpes lesion because they can be spread either to other areas on the same patient, or they can be spread to the clinician if they're not careful. So in clinic, we don't see patients when they have a primary herpetic lesion, but in private practice, you probably will. Then you've got gingival diseases of fungal origin. So these are caused by the Candida albicans fungi. They appear to be bright red. Oftentimes you'll see a fungal origin infection on a patient who's edentulous. And so the denture kind of traps the moisture up underneath it. And if you don't take the denture out regularly and clean it and leave it out for a while for the tissues to sort of dry up, that it will continue to grow and cause an infection. When you do get an infection from Candida albicans, its appearance is red. It can be extremely red. It can be tender to touch. Sometimes the patient will notice it when they're eating or trying to eat. Oftentimes they can't leave their denture in because it hurts too much, which they shouldn't have their denture in then. It's treated with antifungal. There's a mouthwash that's kind of mixed together that has some antifungal liquid in it. It's also got like something that helps keep it so that it sticks to the tissues to help it stay in the area longer. And they just swish with it several times a day to help kill the fungus. Then you've got, gingival lesions of genetic origins. You can have those. Gingival manifestations of systemic conditions. Those are rare, but some of them might be a blood dyscrasia, such as leukemia, which is pretty rare. And then you've got some gingival manifestations of dermatologic disease. So those are immune related and they affect more of the skin. Lichen planus is one that's very common. It's definitely an immune response or an autoimmune response. It affects the skin and the mucous membrane, usually of middle-aged women. It's associated with something called Wickham's stria. So it looks like a spider web or lacy appearance and usually found on the buccal mucosa, although I've seen it on like the gingival margin, but it's usually contained to the buccal mucosa. And it's treated with topical steroids. You have mucous membrane pemphigoid, which is another autoimmune reaction. It appears as blistering and sloughing of the epithelium. It can cause discomfort or be painful. It leaves raw bleeding areas. And it's got associated with something called Nikolsky's sign, which is basically a peeling of the epithelium when it's rubbed. So it's kind of like a pseudomembrane. And then you have desquamative gingivitis, which is the sloughing of the gingiva. So it's 2:54. Let's take another 10-minute break because we still have quite a bit to go through. So let's take another 10-minute break. Come back at like 3:05 and get up and stretch, walk around a little bit, refresh your drink, and we'll meet back at 3:05 and continue with perio. If you think of any questions, jot them down and feel free to ask them when we're talking here in our meeting. Anybody have any questions before we take a break?
I don't think so.
Okay, we'll take your break and we'll meet back at 3:05. All right. Did I say come back at 3:05 or 3:10? Does anybody remember? Is anybody back?
I'm here. I think you said 3:05. I'm not sure though.
Okay. All right. Yeah, I kind of lost track of the time. Okay. So let's see. Let's talk about periodontitis. Periodontitis is an inflammation of the periodontium. It includes apical migration of junctional epithelium and bone loss. It's pretty simply put. The clinical attachment level is more important than the probing depth. So that's something that definitely is a primary indicator of periodontitis is the clinical attachment loss. So we have chronic periodontitis. It contains multiple bacteria. It's the most common form. It progresses slowly and usually horizontally. It occurs after the age of 35. It can be localized or generalized. It has episodic activity, which means it can be going stable or unchanged for a long time, and then something will trigger it and it will just start to break down again. It goes in episodes. It's not associated with a host defect or any kind of blood count defect, and it's caused by anaerobic gram-negative bacteria. So it's the host response plays a role in it and how you react to the bacteria, but you do not necessarily have to have a defect in your response for it to become a disease. In fact, oftentimes it's just your body's reaction to the different types of bacteria. Remember, you can have direct destruction and indirect destruction from periodontitis. Your direct destruction would be when the bacteria themselves attack and destroy the bone and the supporting tissues. Indirect destruction would be that the bacteria trigger a host response, and the host response, or all of the enzymes that your body releases, are what causes the destruction. Or you can have a combination of the two, is usually what it is. So the bacteria most commonly associated with chronic periodontitis is P. gingivalis. And the best treatment for chronic periodontitis is to remove the bacteria or the local problem, local factor. Patient education. So everything from educating the patient on the disease process to educating the patient on how to manage the disease on their own at home. Complete debridement to remove or change the flora. And then we're going to do things that modify risk factors, such as like if they have overhangs on the restorations that are causing plaque buildup, or if they smoke. So we're going to work on risk factors as well. Then we have what we call aggressive periodontitis. Now, you guys are kind of stuck in the middle. So was the last cohort, and probably several cohorts ahead of you will be, where you're going to have to know the old way and the new way. So we're going to talk about the old terms we use for periodontal disease, and we're going to talk about the new 2017 periodontal classifications. Because as you know, we don't necessarily refer to it as chronic periodontitis, aggressive periodontitis, localized periodontitis anymore. But that probably will still be on boards for a while. It will be on your boards, and so it'll probably be on boards still for a while. Aggressive periodontitis has progresses rapidly and has massive bone loss. In other words, making it very aggressive. It can be localized or generalized. Both localized and generalized have very strong periopathogens, like P. gingivalis or AA. And they're usually you will have either early onset, so you're younger than the age of 30 is considered early onset, or you can have just a rapidly progressive on an adult. So early onset, if you're under the age of 30. And it's either prepubertal or juvenile is what they might refer to it as. Most of the time, if you have aggressive periodontitis as a child or a young adult, younger than the age of 30, you've got some sort of white blood cell defect. It's just not common to have a real aggressive form of periodontitis at a young age. And it usually affects the molars and the incisors. You can have juvenile periodontitis that's localized, that affects the molars and incisors. That's the more common type, or you can have it affect all of the teeth. Let's see, then we've got rapidly progressive periodontitis. That's usually happens to people that are a little bit older, in their 20s and 30s, or around 30s, I should say, where you have severe gingival inflammation. You can have lots of plaque and calculus, lots of bone loss, and connective tissue loss. Usually those people have an altered immune system as well, and it's usually going to be neutrophil, or PMNs is what we refer to them as. And then again, the bacteria associated with that is usually P. gingivalis or P. intermedia. So Prevotella intermedia or Porphyromonas gingival. Then we've got refractory periodontitis. Refractory periodontitis is a lot more common. Refractory periodontitis is different than recurrent periodontitis. Recurrent periodontitis is where you have a patient that has had periodontal treatment. So you've seen this patient, they've had scaling and root planing, you did your reevaluation, and they got better. They've got good home care. Their pockets seem to have improved. Their bleeding on probing has improved. Everything about them has improved. And then they're cruising along okay like that. And then one day, things aren't looking so good anymore, and they're showing an increase in clinical attachment loss, perhaps more plaque, deeper pockets, bleeding on probing, maybe even some additional bone loss. That's called recurrent periodontitis. Periodontitis runs in episodes like that, or is episodic, and so that's not uncommon to see those trends. Refractory periodontitis, on the other hand, is where you've done treatment on a patient, but they did not respond to the treatment. So you have a patient come in and you've done scaling and root planing, and they come back for their reeval, and they look like they've done really well with their home care, but they still have deep pockets. They've shown little to no improvement on their clinical attachment loss. They still have bleeding on probing. They're still showing signs of active disease. And so that's your refractory patient. So now we have to do something else. We can't just put them in perio maintenance like that. We usually need to do something else. Oftentimes, it can be systemic antibiotics. It could be retreating with perio, scaling, and root planing. But something else needs to be done. And so those are your refractory patients. There's no specific bacteria found in those patients. If the patient continues, you do, let's say you do systemic antibiotics, and the patient comes back in and they still haven't gotten better. Usually that's a time to start looking into other health issues with the patient. Like, are they pre-diabetic? Is there something else going on with their body that's causing them not to respond to traditional treatment that should get a good response? So that's refractory. Separate, different from recurrent. Perio is a manifestation of a disease. So you have a disease such as diabetes or AIDS, Down syndrome, and they all increase the severity of the periodontitis. So a patient has periodontitis and they have one of these diseases, so their response to bacteria is going to be different, and so therefore they're going to have more of a severe case of periodontal disease. You have necrotizing periodontal diseases. Those are usually found in immune-compromised individuals. NUG is found in individuals that are under high stress. NUP is usually, when NUG is progressed, NUP has a much more severe reaction and more destruction, usually in compromised patients, like a patient that has AIDS. Abscesses. Abscesses are usually bacterial. They're associated with an accumulation of pus or purulence in the periodontal tissues. So you can have different types of abscesses. We have periodontal abscesses. Periodontal abscesses are usually found in chronic periodontal patients. The abscess itself can be acute or chronic. If a periodontal patient has an acute abscess, they have pre-existing periodontal disease. They can get rapid bone loss. It oftentimes occurs following scaling and root planing. Probably sometime in your professional life, you are going to have a patient get a periodontal abscess after you've done scaling and root planing. And it's usually because you've left behind some calculus. So you've gone in and you've stirred up the bacteria, but you didn't get the site cleaned out really well, and the patient ends up with an abscess. It happens to almost everybody, or probably everybody. It's associated with throbbing pain. So acute abscesses have throbbing pain. So one way to keep them kind of straight is think about it. If you had throbbing pain, it's going to come on pretty suddenly because you're going to do something about it pretty quickly. It's a more acute situation. There's swelling. There's often mobility of the tooth. The patient says that the tooth hurts or feels like it's biting high. Unlike a chronic periodontal abscess, which is due to, is usually asymptomatic because the pus is draining. So the acute one has pus that's kind of contained, and the chronic has pus that's draining, so it doesn't usually have any pain associated with it. That's why it becomes chronic, because there's no pain associated with it. If you had throbbing pain, you wouldn't be sitting there just letting it go usually. So acute are associated with pain, chronic, no pain. You can have gingival abscesses. Gingival abscesses occur in disease-free areas. So any one of you could get a gingival abscess at any time. It's usually related to a forceful occlusion of some sort of foreign object into the gingival tissue. So you eat popcorn and you get a popcorn hull stuck in your gum and you don't realize it. Normally, but popcorn will work its way back out, whether it's through good brushing and flossing, or it just works its way back out on its own anyway. Sometimes you eat popcorn and 2 or 3 days later, even though you've brushed and flossed your teeth several times over those 2 or 3 days, all of a sudden a piece of popcorn comes out from somewhere. And you've got this popcorn hull floating around in your mouth. And so if that popcorn did not free itself from wherever it was hiding, it could become a gingival abscess. Then we have pericornal abscesses. Pericornal abscesses occur around partially erupted teeth, are called pericornitis. And the flap of tissue is called the operculum. It doesn't necessarily have to be a third molar, even though the third molar is the most common place to get it because it's most common area to have an unerupted tooth or a partially erupted tooth. But it can be a second molar. So they can occur anywhere. But once you have the operculum and you bite on it or irritate it with some food or something, You're going to keep biting on it. It's going to stay irritated, and eventually it's going to get infected. So then we have periodontitis associated with endodontic lesions. So when you remember an endodontic lesion, or a lesion that needs a root canal, has inflammation and infection in the pulp of the tooth. So it's actually the inside of the tooth that has the problem. What happens though is, since the apical foramen is open, or there's an opening at the bottom, bacteria can run from the pulp canal out the apical foramen and into the surrounding tissues. So oftentimes you'll see a radiolucency at the apex of the tooth when a patient has a periapical abscess or an endodontic lesion. But what can happen is that bacteria can work its way up the periodontal ligament or the side of the tooth and drain out the top. And the bacteria then, it will relieve the pressure so it won't hurt, so the patient may not notice it, but the bacteria will start to damage the surrounding structures, the tissue, the bone that surround it, causing it to become a periodontal/endodontic lesion. And so when you have a lesion like that, the first form of treatment is going to be to get the endodontic lesion under control. You don't want to scale and root plane until after you've had the endodontic lesion heal, because the scaling and root planing disrupts the attachment of the fibers on the root surface. So you don't want to disrupt that attachment until you've given it a chance to heal. Developmental or acquired deformities and conditions. So you can have pseudo pockets, which are fake pockets. Pseudo pockets are caused by inflammation or swelling of the gingival margin, making the pocket seem deeper. They can also make plaque control more difficult. And then you can have gingival recession, which results in underlying osseous defect. So gingival recession can also cause a deformity or be a deformity or condition. Variations in normal bone, such as dehiscence, where an area of bone is resorbed over the facial surface of the root, or you can have a fenestration, which is like a window covering, or an opening or a window in the bone covering the facial surface of the root. You can have furcations. They're another deformity or condition. Furcations are difficult to clean. They're difficult for the patient to clean. They're difficult for you to clean. We use a Nabors probe, NABOR''S, Nabors probe, to measure furcations. Furcations are classified by how deep you can get into the furcation. So they go from 0 to 4. Zero would be no furcation involvement at all. Most furcations hopefully should stay at 0. A 1 is a beginning lesion. So you can start to feel that little V shape. You're coming across the front of the tooth, or the buccal surface of the tooth, and you kind of dip in like a V on the tooth. At that point, there's no infrabony lesion yet. You're just getting that little shallow, deep notch. Then on 2, you have an open lesion or some horizontal destruction that goes into the furcation. So you have the top, you can feel the top, you can feel the sides, and you can feel the tissue on the bottom. So you can actually now kind of feel a triangular area that's open there. Classification 3 is through and through. So when they say through and through, that means that you can pass your explorer through it. So if you stick your explorer through, it comes out the other side. Be careful doing that so you're not poking into the tissue. But you can actually pass your explorer through and through. And a furcation classification 4 is where you can just see it with your eyes, like you can see through the furcation. You will see teeth that are hanging on that have classic 4 furcations. They're not the most stable or best teeth, but I've seen teeth go for, 8 or 10 years with visible through and through furcation. The patient uses a water pick usually, and oftentimes they can even get a small proxy brush through there. They can dip it in chlorhexidine or Listerine or something and run the proxy brush through, flush it out with a water irrigator or water pick, and they can keep it pretty clean and make it last a while, even with the through and through furcation. Then we have mobility. Classifications of mobility. Again, we start with 0. We have no mobility evidence. So nothing, no mobility. And then a plus we call slight mobility compared to the general nature of the patient's dentition. I've not really seen them use pluses very often in mobility classification. A class 1 is slight mobility of at least 1 millimeter buccal facial lingually. So you can rock the tooth about 1 millimeter. Now think how small 1 millimeter is. And the fact that the tooth has a slight bit of mobility because the PDL gives it some mobility. So differentiating that and then throwing in a plus in between would be really kind of hard to differentiate. So I usually have just seen a 0 jump to a 1. Then we've got mobility classification 2, which is moderate mobility of 1 to 2 millimeters rocking facial lingually, or even maybe mesiodistally. So you might have a little bit of rocking this way and some rocking this way. And then classification 3 is advanced mobility. So you can move it 2 millimeters facial lingually, and often it's depressible in the socket. So in other words, if you took your finger and you press down, you can feel it move up and down. That's a tough situation. So case types. Let's talk about case types. Again, you guys are going to get stuck. You're going to have to know case types and the new classification system and the mild, moderate, severe that was in between case types and the new system. So years ago, we used something called case type. So a case type 1 was gingivitis. So you had no radiographic evidence of crestal bone loss. So the alveolar crest looked completely intact. Case type 2 is equivalent to what we would call mild periodontitis or stage 1 periodontitis now with using the new system. You have a progression of gingival inflammation into the alveolar crest, and early bone loss is seen. You can have pocket formation of 2 to 4 millimeters, and the bone loss is primarily starting at horizontal. Case type 3, also considered moderate periodontitis or stage 2 periodontitis in our new staging and grading system. You have a little bit more advancement. You have increased destruction. You can have deeper pocket depths. Now in here, in case type 2, it says you can have 5 to 7 millimeters. Our case type 2 or our stage 2 doesn't usually have that deep of pocket depth. You can have moderate to severe bone loss in this and tooth mobility. I'm sorry, I'm looking at the wrong thing. No, that's right, case type 3. I'm sorry, moderate to severe bone loss. We don't consider that to be moderate. We consider for case type 2 or stage 2 to have less than that. Their case type 4 was severe. Our stage 3 is severe. So you can have deeper pockets, you can have more mobility, more destruction. Look over the case types and kind of have a feel for what the case types are about, because they may have some questions about case types on there. Periodontal prognosis. The thing to know about your prognosis is like your outcome or your long-term outcome. Where is the patient going from here? Your diagnosis tells you where they are today. Your prognosis tells you where is this headed. One of the biggest factors for your prognosis is your patient's attitude. Their health, their oral hygiene level, and their age. All of those factor into the prognosis. If your patient has a bad attitude and your patient says, I'm not going to do any of those oral hygiene things you told me to do, well, then they're not going to probably, the prognosis for their teeth is going to be poor or less favorable than somebody who's gung-ho and ready to jump in and do everything you tell them. If they have systemic health problems, the patient was diagnosed with diabetes, type 1 diabetes, and they have an A1C of 10.0, their prognosis is going to be less favorable than somebody who's healthy. Age kind of automatically kind of makes their prognosis a little bit compromised, only because with age, you can have health issues, you can have dexterity issues, you can have attitude issues. So we do kind of take into account the patient's age. Now, the patient's age should not stop you from presenting a complete treatment plan or making recommendations. It affects the prognosis to some extent, but it shouldn't stop you from presenting all of the treatment options to the patient. Let's see. The level present of the situations within their oral cavity, including like furcations, their amount of attached gingiva they have, any mobility issues, their bone height, their attachment loss, their past disease, all of those things, malocclusion, all of those things need to also be taken into consideration in the prognosis. If they have grade 3 furcations, they're going to have a hard time keeping the teeth no matter what. And that's going to make the prognosis for the teeth a little bit poor or more compromised. Periodontal surgery. So some of these periodontal surgery things you may have forgotten because we don't really see a lot of periodontal surgery things coming across in the clinic. So we have different types of surgery. We have pocket reduction surgery. Pocket reduction surgery is done so that you can better access your home care. So that would be like your gingivectomy. The patient has thick overgrown tissue that retains plaque. So they're going to go in deep pockets. Because of that, they're going to go through, they're going to remove that thick excess tissue and make it easier for the patient to access oral hygiene practices. Things like deeper pockets that are hard for the patient to access because they have a lot of thick, maybe bulbous interdental papilla. So the periodontist goes in, flaps the tissue, cleans out the necrotic tissue, and closes the flap back up. It creates space between the teeth. It doesn't leave an aesthetic result, but it reduces the pocket and makes it easier for the patient to keep it clean. Then you have correction of mucogingival defects. Patient has a recession or a mucogingival defect, and they graft tissue over it in order to correct it. It can be done cosmetically or therapeutically. Removal of inflamed tissues kind of falls under that pocket reduction. Drainage of infections, same thing. You can go in and maybe you need to drain a periodontal abscess so they can flap the tissue, clean out the pus, clean out the dead tissue, and close it back up so that the patient can clean it at home much more easily. Provide access for restorative procedures. Crown lengthening is a procedure that's commonly used for that. So the patient fractured a tooth at the gum line and you want to place a crown. It might be kind of difficult to place the crown without anything for the crown to grab onto. So oftentimes they'll do a procedure called crown lengthening where they go in, flap the tissue, grind the bone away a little bit, lower the foundation down so that a little bit of the tooth is sticking up, and then a crown can be placed or seated over that. Regeneration of the pocket or of the periodontium is like bone grafting. So the patient has a vertical defect in the bone. You go in, flap the tissue, clean out the dead tissue, graft some bone in the vertical defect. The bone will grow back, getting rid of or removing the vertical defect and reducing the pocket. And then approved aesthetics could be anything from like gingival overgrowth or gingivectomies. And then there's placement of implants. Treatment planning for surgery. There's different things to know about treatment planning. You need to be able to take into consideration how deep are the pockets. So you don't want to necessarily do surgery on a patient that has a 5 millimeter pocket. It's usually reserved for deeper pockets. You have to have more than half of the bone remaining. So if you have what we call a one wall defect, where you only have one wall left supporting the tooth, you're not going to be able to grow back or graft that much bone to give it complete bone support. So that would not be an example of what would not be enough bone. You need to have about 50% of the bone remaining. Less than half of grafting or regeneration needed. Again, if the vertical defect goes all the way to the apex of the tooth, you're probably not going to be able to graft enough bone in there to save the tooth. Take into consideration the need for the tooth to function. So if you've got a tooth, like say you've got tooth number 31, but you're missing teeth numbers 2 and 3, is it worth it to do periodontal surgery on tooth number 31 when it's not even in function with any other teeth? So you might save that tooth and make it an easy to clean and good, healthy area, but it's not doing anything. It's not occluding with anything. And then the patient's health has to be taken into consideration. If the patient has uncontrolled diabetes with an A1C of 10.0, their healing is not going to be that good. So you can graft bone or you can do all kinds of surgery, graft tissue or whatever, but they're not going to heal. Not like they need to. So we talked about those are the types of periodontal surgery. You've got flap surgeries for pocket reduction. You've got gingivectomies, which are done for pocket reduction. You've got bone grafting, which is done for regeneration. So reduction surgeries are going to take away deep pockets. Regenerations are going to build up your foundation. They're also going to take away deep pockets, but in a different way. So instead of bringing your house down to the level of the foundation so you can clean it, we're going to bring the foundation up to the level of the house so you can clean it. So reduction would be you want to reduce the pockets by bringing down the tissue. Regeneration, you want to reduce the pockets by bringing up the bone levels. Guided tissue regeneration, or GTR, is a membrane that's placed at the surgical site that allows for selective cell repopulation. I think that's about the only thing you really have to know about guided tissue, is that it allows for selective cell repopulation. Bone heals more slowly than tissue. So when you have a surgical site, what you want to do with the guided tissue is you want to stop the epithelial cells or the soft tissue cells from filling in before you allow the bone to fill back in. The types of bone grafting? I know there's questions about this on boards. I've heard it every year from every cohort. An autograft is where you take bone from the patient themselves. Think about your autograft. Your autograft is your own signature. It's taken from you. Allografts are taken from cadavers. We used allografts a lot in perio. They're taken from a cadaver. Xenografts are taken from a bovine or a cow or a pig. And then alloplasts are synthetic materials. They use a lot more alloplasts now too. They make their own tissues for grafting. They make their own bone materials that are synthetics. It's easier on the patient a lot of times than having a chunk of their palate cut out. You have mucogingival surgeries. Recession and mucogingival defects were typed, as in type 1 and type 2 and type 3, 4, and 5. We did not really study them by types. If they were to ask you about types of defects, the type 1 and the type 2 are the most common. The type 1 defect of a mucogingival defect are pockets extend apically, but you still have a firm amount of keratinized tissue. And then the type 2 defects mean you have no zone of attached gingiva. And then you can have implant surgeries. Implants are placed to replace a single tooth or support a denture. You can do a bridge with implants as well. There's the submerged and unsubmerged. The submerged required a second surgical procedure to uncover it. That's where the implant is submerged under the tissue at the height of the alveolar bone, and then the tissue's folded back over it during the healing time. The unsubmerged is where the implant screw is placed at the height of the bone and the abutment is placed right away so that the abutment sticks out of the tissue. So after the bone and everything is healed, it doesn't need to be uncovered, or there's no second surgical procedure. Endosseous are the most common. Root form endosseous are the most common. There's blade form as well, but they most commonly use root form. In other words, it looks like it's a single screw that looks like the root of a tooth. They're threaded usually, but they can be cylindrical or smooth. Threaded is more common. They're made of titanium. Titanium is very well accepted by the body, and that's why it's used most commonly. Let's see. So for maintenance of implants, usually for the maintenance of implants, you can use plastic scalers to disrupt biofilm, but titanium scalers are used to remove calculus. Titanium scalers are the new and upcoming scaler of choice. Implants usually require a 3-month recall for the first year. Now, that's a board type question. In reality, you should keep a patient on a 3-month recall all the time with an implant. But for boards, the purposes of boards, it's for the first year. And they mainly collect supragingival calculus and plaque. You do not use any abrasive polishing agents on the implant itself, or on the implant crown for that matter. So peri-implantitis and peri-implant mucositis. Peri-implant mucositis is like gingivitis on a tooth. Peri-implant mucositis only affects soft gingival tissues. Peri-implantitis is like periodontitis on a tooth. It affects the surrounding structures. It has bone loss. An implant, when it loses bone, it will lose bone either in a vertical or a saucer, meaning like a rounded elliptical shape. And an implant should have no mobility. A healthy implant should have no mobility. It has no mobility because it's osseointegrated. So in other words, the implant and the bone interface together. There's no periodontal ligaments around an implant. There's no cementum on an implant. So there's no Sharpie's fibers. There's no periodontal ligament. There's no Sharpie's fibers to attach it, even if there was. They have yet to find ways to get periodontal ligaments to grow around an implant. Sutures and dressings, as far as sutures, resorbable sutures will dissolve on their own. Non-resorbable have to be removed usually in 7 to 14 days. Perio packs are placed to cover sutures to make them more comfortable, but the perio pack itself does not stop bleeding. Let's see. Surgical healing. Surgical healing starts with the formation of a blood clot. So the formation of the blood clot is what stimulates the healing process. Epithelial cells start to migrate into the area in 7 days. Osseous or bone healing does not begin until at least 1 month after surgery and is not completed for 4 to 6 months. So if you were to have a surgeon do a bone graft on a patient and you took a radiograph at a month, the patient would start to have some epithelial attachment, but they would not have any bone healing yet. So the surgical site would look the same. So osseous healing is a lot slower than soft tissue healing. Wound healing begins after the blood clot forms. A dry socket can occur. It's painful. Usually the patient experiences bad breath and pain when they have a dry socket. As far as the inflammatory process, you get vasoconstriction, vasodilation, exudate, and then mast cells. So when healing occurs, the first step in the repair is the formation of the clot. And then after that, you get your inflammatory cells that come into the area. Your PMNs and your macrophages are the first ones to invade the area and to start to heal the process. So occlusal trauma, as far as occlusal trauma goes, and your TMJ, TMD, terms to know: bruxism is grinding of the teeth. It can cause periodontal injury and pain. So it can injure the periodontium. Periodontitis, though, however, is bacterial related. So bruxism can be a contributing factor, but it is not a cause of periodontitis. Clenching is clamping or forcing the teeth together without use of physiologic rest. So people clench their teeth a lot of times at night when they're sleeping. A lot of people clench their teeth when they're awake too. Clicking of the TMJ is a cracking or snapping noise because of the disc and the condyle in coordination. So they're not coordinating their rotation, and so you get a clicking. Crepitus or crepitation is a grating noise. So it kind of makes like a grinding kind of sound or feeling. Fremitus is a vibration on a tooth. So one way to check a tooth when you have when you're trying to see if it's suffering from occlusal trauma is to take your finger and lightly touch the tooth and have the patient tap their teeth together. If the teeth are hitting hard, you'll feel a vibration on the tooth that's being hit or traumatized. Parafunctional habits are movements of the mandible outside the range of normal. So grinding, clenching, those are parafunctional habits. Myalgia is a pain in the muscle. A spasm is an involuntary contraction of a muscle. It's usually painful. And trismus is a spasm of the masticatory muscles associated with the disturbance of the trigeminal nerve. Any questions so far? Anything you can think of?
I don't think so.
Are you all still awake?
Yeah,
Yes.
just lighting away.
All right. We're almost done, believe it or not. Primary traumatic occlusion is when you have heavy occlusal forces exceeding the adaptive range of a normal periodontium. So primary traumatic occlusion is when you have heavy forces on a normal periodontium. Secondary traumatic occlusion is when you have normal occlusal forces that exceed the capacity of a periodontium that is already affected. So primary, secondary. All right, let's see. Abfractions. Abfractions are caused by lateral forces on the teeth. When caused by lateral forces on the teeth placed there by occlusal interferences in lateral excursions. So in other words, it has to do with the occlusal forces on the teeth that are not normal or not hitting properly can cause abfraction. Those are those little triangular like divots in the tooth surface. Just a few little things to remember, and then I have one more thing to go over that's new. Gram-negative species of bacteria are the primary etiology of periodontitis. Gram-negative bacteria. Lipopolysaccharides are the same as endotoxins. They're on gram-negative bacterial cell wall components. And they induce the inflammatory response and stimulate osteoclast activity. Osteoclasts break down bone. Osteoblasts build bone. Lymphocytes, PMNs, and plasma cells are found in chronically inflamed tissue. So chronically inflamed tissue has inflammatory cells in it that are causing destruction. Most important factor for determining recall frequency for a perio-maintenance patient is the patient's oral hygiene. So if the patient comes in and has poor oral hygiene, they are going to need a more frequent recall visit, a recall schedule. To evaluate a patient's oral hygiene and plaque control, evaluate the condition of the gingiva. So if the patient comes in and they have really severe gingivitis or moderate to severe gingivitis, and they have no plaque on their teeth, rather than jumping into right away thinking that they have some rare disease or some rare non-plaque induced gingival disease or condition, think about the fact that maybe it's just because they just brushed and flossed their teeth really well today because they know they're coming to the dentist. But they normally don't, and that's why they have gingivitis. Let's see. Periodontal abscesses can occur after scaling and root planing. Gingivitis cannot be detected radiographically, so remember that. The redness of early gingivitis is caused by dilation of blood vessels, the early signs of gingivitis. Remember, the early signs of early gingivitis has no clinical signs. The initial stage of gingivitis has no clinical signs. Early gingivitis is when you start to see clinical signs. Stress, smoking, poor oral hygiene, and fatigue contribute to the development of NUG. Destruction of the facial and lingual cortical plates is often not detectable on radiographs. So what we're usually looking for on radiographs is interproximal, interdental bone loss, because we can't see facial and lingual. Those are just some things to keep in mind. So Dr. Thurlow said that some of you had some questions or were unclear about the difference between your dental hygiene diagnosis and your periodontal diagnosis.
Yes.
Okay. So we kind of in clinic have gotten lazy and gotten into the habit of using them interchangeably. Your dental hygiene diagnosis is your perio diagnosis. So we've gotten to where we say we just put them in both spots. Periodontitis stage 3 grade B. And we put that, or we put our dental hygiene diagnosis as periodontitis, and our periodiagnosis will write stage 3 grade B. So to clarify that, technically, your dental hygiene diagnosis encompasses more than, it includes but encompasses more than your periodiagnosis. Your periodiagnosis is gingivitis, periodontitis. The staging and grading is supplemental information. So think of it like cancer. Patient has breast cancer. They stage and grade the breast cancer. It tells you how bad is the cancer and what's its likelihood to continue at a rapid, slow, moderate, or rapid rate. How likely is it to be halted by treatment? So they stage and grade it. But your diagnosis is breast cancer. So when we're diagnosing, our diagnosis is gingivitis or periodontitis. All the other words are sort of descriptors to help us understand the disease process. Is it localized or generalized? Okay, we have generalized periodontitis. The stage and grade tell us how bad, or what does it present today? How bad is it today? So we're going to stage it. It's stage 3. It's pretty moderate. And how likely is it to progress at a slow, a moderate, or a fast rate? So now we're going to grade it. Is it likely to respond to treatment well and be slow? Is it likely to progress moderate? Or is it likely to progress rapidly? So that's your diagnosis, your periodontal diagnosis. Your dental hygiene diagnosis takes other factors into consideration, such as your risk factors. The patient has hypersensitivity. The patient has xerostomia. The patient has poor oral hygiene. Patient has maybe, I said xerostomia, maybe they have an increased caries risk. So all of those things factor into your dental hygiene diagnosis. They all have an effect on your periodontal condition. So when you're writing up your dental hygiene diagnosis, you should be listing each of those things as being a risk factor to your periodontitis. Like I said, we don't do that in clinic. We kind of do it a little bit more on the lax or lazy side. When you are in private practice, particularly if you decide to work in a perio office, but even if you don't, when you have a perio patient in your chair, you are going to write in your clinical notes how these things affect the patient. So if you've got a patient that's a stage 3 grade B periodontal patient and they smoke, or stage 3 grade C, and they smoke 2 packs of cigarettes a day, you're going to list that in your diagnosis section of your note. You're going to say patient smokes 2 packs of cigarettes a day or 2+ packs of cigarettes a day. That's going to give you and the next clinician some idea of how you view the patient's problems. If the patient has diabetes and their A1C is 9.0, you're going to put that in or specifically name that as a potential risk factor for the patient's periodontitis. If the patient is at a, let's say they're an adult prophy, but they have a high risk of dental caries, you're going to list that your patient is at high risk for dental caries. And under your treatment, you're going to list that you've recommended, maybe it's going to be a fluoride rinse at home, like ACT fluoride rinse. Maybe you're going to have your patient prescribed a fluoride gel that they're going to brush on at home because they're at a high risk for caries. But you're going to take all of these things into consideration. You're not just treating their gums. directly. You're also treating things that affect their gums. You're going to counsel them on smoking cessation. So you're going to write that the patient has xerostomia related to their medication. You're going to write that the patient, maybe the patient has some inflammation around tooth number 31 due to plaque accumulation. They have hypersensitivity because they have generalized recession. So that's all part of the dental hygiene diagnosis. Think of the dental hygienist as more than just treating that one particular symptom. You're treating things that contribute to it as well, or you're acknowledging it and you're referring them to people or places that can help them. Now, you're not going to pick apart every single little thing about them, but you're going to certainly zero in on the things that have a definite influence on their periodontal status. How did they get to a stage 3 grade B? How did they get to a stage 4 grade C? Oh, they smoked 3 packs of cigarettes a day for 50 years. So, you know, all those things that are really have a dramatic effect or need to be addressed goes in your dental hygiene diagnosis. Your periodontal diagnosis is strictly your periodontal diagnosis. Does that make sense?
Yes. So in the dental hygiene diagnosis, we're basically putting patients like risk factors or things that could contribute to, you know, problems down the road or even currently. It's not just stage whatever, grade whatever.
Correct. So you might even like your plaque index is a good one to list. Like if the patient has a plaque index of 65%, you're definitely going to want to address that. Patient has a plaque index of 65%. Even if they're only having like say mild gingivitis right now, that's 65%, if it stays that way, is going to become at some point a major factor in their periodontal condition. So those are all things that you should be addressing. When you're doing your treatment plan, I think for the most part, many of you, I mean, I haven't seen a lot of your because we don't do the written treatment plans, you guys aren't. The next cohort's back to doing them. But those would be maybe some of the things you would address in your treatment plan as well. Maybe you want to give them information on tobacco cessation, or you want to refer them to a clinic or something to address their tobacco habit, things like that. Anybody else have any questions?
I have a question. So for the perio stage and grade, we'll just put the stage and grade, but are we actually writing out like mild, moderate, or severe anywhere now?
We don't, since we're using the staging and grading, you don't have to, no. You should put generalized or localized, and then whatever it is, gingivitis or periodontitis. So you might have your diagnosis as generalized periodontitis, and then you'll stage and grade it. On gingivitis, I would put mild, moderate, or severe because we don't have really any other way to differentiate gingivitis. So if you put like mild gingivitis, generalized mild gingivitis, you could say like papillary or marginal to give it more of a descriptor. But gingivitis, they don't have as like defined as periodontitis. I think because periodontitis is a much more variation in how you're going to treat it. When you have a patient with moderate gingivitis or you have a patient with severe gingivitis, you're kind of going to treat it the same way. You're still going to like thoroughly clean them, work on their oral hygiene. But when you have perio, you're going to treat perio differently at different stages and grades. But in private practice, I would guess that it's likely that many of you, when you get out in private practice, your practice is not going to be using the new system. If they are, that would be great because you're 4 steps ahead of the game. And you may be the game changer for your practice. You know, you may be the one that comes in and says, oh, this is so much better. You know, this is how it works. A lot of people, a lot of doctors, and a lot of even hygienists have not changed over because it's unfamiliar. They just don't understand it. When I did that CE for the Missouri Dental Hygienists Association a few weeks or months ago, a couple months ago, I guess it was now, most of them said that exact thing. They haven't used it because they didn't understand it and they just never took the time to learn it. And so, you know, if you get in an office that's still using, well, hopefully not case types, but the other system, you might be the one that goes in and teaches them how to use the chart. I would keep that chart handy for future reference. Did that answer your question?
Yes. So then if the patient was like healthy or if they had the gingivitis, just where it says perio stage and grade, you would either write healthy or like localized gingivitis or something like that?
Yeah, I wouldn't put it where it says stage and grade. I would take out the stage and grade, and then I would just put like if you're going to say like mild marginal gingivitis or something like that. Staging and grading only goes with periodontitis diagnosis. So you could either take it out, or I think Professor Ramos didn't want you guys to take it out, so just put NA on those because they only pertain to perio. So if you have
Okay, that makes sense.
Yeah, so if you have gingivitis, you can put your descriptors there, but just don't put them under the stage and grade because that'll get confusing. Anybody else have any questions about that? So I went back through when Dr. Thurlow asked me, how do you teach this in perio about the dental hygiene diagnosis versus the perio diagnosis? And I went back through your perio textbook and I couldn't find anywhere in there where it talks about dental hygiene diagnosis, but it has like one sentence and then it goes right into the periodontal diagnosis. So I thought, well, let's get out a different book. And so I got out the new textbook and it kind of does the same thing. So we found this in the Wilkins textbook. And so this is chapter 22 of your Wilkins book. If you want to look at it a little bit, I think it's, well, this is chapter 22 in the old Wilkins the new Wilkins textbook. But if you look it up in the old, it might still be chapter 22. You guys have the older one. But you can look up dental hygiene diagnosis in the back of the book and see where it is in your textbook and just read these couple of paragraphs to sort of help explain it to you. It gives you examples of the dental hygiene diagnostic statements where it says like hypersensitivity related to gingival recession. It says biofilm control score or plaque index, and then it says like whatever the plaque index is related to limited ability to perform oral hygiene tasks. So it kind of gives you some examples if you want to look that up. Like I said, in the new Wilkins book, which Dr. Thurlow has one in her office if you decide you want to look it up in clinic, like when you have downtime or something, it's chapter 22. So, but if you wanted to do it at home, just look in the back of your book and see where it is. I don't think the new Wilkins book should be a whole lot different as far as that kind of stuff goes. I know they update like all the infection control stuff regularly, but usually that kind of stuff doesn't change very often. Anybody have any other questions? Are you guys all ready excited about getting ready to take boards?
No.
I can't believe we're doing this. Like, it seems like not that long ago, we were sitting in a Teams meeting learning Perio. I mean, it's like you blink your eyes and time goes by.
I'm so scared.
Take the test or scared of moving on?
Both, yeah.
I know a lot of students have given us feedback a lot of times where they said that like they've gotten out in private practice and they get their first job and they go to work on like their first day and they finish their patient and then they're like, oh God, nobody's checking me. What am I going to do? Like, what if I missed calculus? What if I didn't get all the stain off? What if I didn't do this? What if I was off on my probing depth? And then they're like, yay, nobody's checking me. Like, I can let the patient go and I don't have to wait for faculty to come and check me, you know? So they transition pretty quickly from being scared to being happy. So I'm sure you guys will too. Just be confident. Didn't Director Beckerly give you recently a pep talk about saying things confidently? Like it's better to be confidently wrong than not confidently correct or something along that lines, right? So,
Yeah.
so take that advice, say it with confidence, and if you're wrong, you're wrong. Not the end of the world. Boards will come and go, and before you know it, you will have your license and you'll be out there. Buying a new car or something.
Thank you.
You're welcome. You guys, good luck, everybody. And if you think of anything else, or if you're going through like dental decks or something and you won't have questions, feel free to bring them to me and hopefully I can answer.
Thank
Did you say there was an assignment?
Did I what?
Mention something about an assignment?
I do have some stuff. I will pull off of the board review refresher course that the other cohort had to do since they were gone for term 7, and see what I can find for you guys to do for practice if you want.
I would greatly appreciate that. Thank you.
I'm sorry, did somebody else ask a question? Nope. Okay. All right, well, good luck, everybody.
Thank you.
Bye. See you tomorrow. Andrea, are you still there?